Okay. Preterm birth prevention. She has previous history. Oh, she does not have any chronic. Okay, preterm birth prevention. Prior preterm delivery, no, no. Second trimester, transvaginal ultrasound. Prior preterm delivery, no. Second trimester, transvaginal ultrasound for cervical length. If normal cervical length, routine care. If it is incidental, short cervix. If there is incidental short cervix, then we will give a vaginal progesterone less than 2.5 centimeter at less than 24 weeks. Yeah, prior preterm delivery, yes. Prior preterm delivery associated with a contraction. If there is painful contraction, yes. Prior preterm delivery give progesterone, IM or vaginal. No. Cervical insufficiency, prophylactic circulation. Cervical insufficiency, prophylactic circulation. So during the initial visit, risk factor for potential obstetric complication are assessed to follow for the implantation of the preventive measure. This patient has prior cold knife conization for is at risk for preterm delivery at less than 37 weeks. Preterm delivery is a common obstetric complication and a leading cause of neonatal morbidity and mortality. The greatest risk factor for preterm delivery is prior spontaneous preterm delivery, but additional risk factors include tobacco use, multiple gestation, prior cervical surgery. In particular, removal of part of the cervix by cold knife conization for cervical interepithelial neoplasia can cause cervical shortening and scarring, which decreases the cervical tensile length, strength, and increase the risk of preterm labor. For patients with no preterm delivery, a transvaginal cervical length measurement is recommended at 16 to 24 weeks of gestation to assess the risk for preterm delivery. Patients with normal cervical length are at a lower risk for preterm delivery and require no additional intervention. In contrast, those with a short cervical length less than 2.5 cm on ultrasound are at high risk for preterm delivery and are offered vaginal progesterone, which can prevent uterine contraction and preterm labor. Okay. Yes. I don't think that general people does it. If there is, that's why we are looking for the indication why she has done it, because uh, in this 16 to 18 in these 16 weeks of gestation, in case of female, they do not need any sort of investigation. As far we remember, the 22 to 24 weeks, there is hemoglobin hematocrit. There may be like 50 gram GCT, and there is another, like if there is RH antibody, so they do not need it, as she has cold knife conization 2 hours back, so cervix may be, there may be cervical insufficiency or there may be shortened cervix, so we are looking for that. Normal vertex presentation. So this baby can come easily through the vaginal wall, but the cervix is only 4 centimeter dilated, not full dilated, like 10 centimeter dilated. So she is in probably first stage of labor. So fetus station is 3 minus 3. The baby does not have any problem. Is there any problem? Sorry? No, no, we do not give emergency cervical circlage at that age. May not be. I think that it is expected management. Emergency usually cervical circlage given at the early pregnancy, and it it we will open this circlage within maybe 30 to near about these weeks. It is not given at that 35 weeks. Okay. So, okay, I am reading the circlage first. Emergency cervical circlage is indicated for patient with acute cervical insufficiency, painless cervical dilatation less than 24 weeks of gestation. However, this procedure is inappropriate at more than 24 weeks of gestation due to increased rate of failure and maternal cervical insufficiency and increased gestational age. So, circle should be given before 24. Circle 24. Circle 24. Okay. And if you look at this, for preterm labor, if there is maternal instability or intrauterine infection or fetal demise or fetal distress, if that is present, then we will immediately do the delivery. If it is not, if no, then we have to look for the weeks. If it is less than 32 weeks, then APTM, apartment M, A for antenatal corticosteroid, P for penicillin, T for tocolytic, M for magnesium sulfate. And for 32 to 34 weeks, APT, that means antenatal corticosteroid, penicillin, and tocolytics. In here, we use nifedipine as a tocolytic. Nifedipine side effect is it can cause reflex tachycardia. Okay. And for 34 to 37 weeks, we use AP, that means antenatal corticosteroid and penicillin if GBS or unknown. So I remember the APTM, apartment M. So for less than 32 weeks, 4, 32 to 33, 3, and for 35, 34 to 37 weeks, 2. We need 2. Okay. So this patient at 35 weeks, this patient at 35 weeks of gestation with regular painful contraction causing cervical dilatation in preterm labor at less than 37 weeks of gestation. Risk factor include short cervical length on transvaginal ultrasound, as in this patient prior spontaneous preterm delivery and multiple gestation. The management of preterm labor is largely dependent on gestational age. At more than 34 weeks of gestation, tocolytic agents such as indomethacin or nifedipine are recommended temporarily to halt contraction and delay labor because the risks of indomethacin, oligohydramnios, and closure of the PDA and nifedipine is maternal hypotension or tachycardia outweigh the neonatal risk of preterm delivery. Therefore, patients in preterm labor more than 34 weeks of gestation who have no contraindication to vaginal delivery, placenta previa receive expectant labor management. In addition, patients in preterm labor may benefit from administration of antenatal corticosteroid betamethasone to decrease the risk of neonatal respiratory distress syndrome. However, the use of corticosteroid after 34 weeks of gestation is not universal. Patients who are either group B streptococcus positive or unknown require penicillin prophylaxis. Next. Okay. Oh, maternal serum alpha fetoprotein screening. Maternal serum alpha fetoprotein screening, if it is high, open neural tube defect, anencephaly open spina bifida, and a ventral wall defect, omphalocele gastroschisis, and multiple gestation. Open neural tube defect, anencephaly open spina bifida, ventral tube defect, and multiple gestation. And decrease maternal serum alpha fetoprotein aneuploidy and trisomy 21. Alpha fetoprotein is produced by the liver and gastrointestinal tract and is present in the serum and amniotic fluid. It is observed into the maternal circulation and is measurable as maternal serum alpha fetoprotein. Maternal serum alpha fetoprotein is one of four markers. Maternal serum alpha fetoprotein unconjugated estriol beta hCG and inhibin A, comprising the quadruple marker test, a screening test for aneuploidy and congenital defect. Elevated maternal serum alpha fetoprotein level commonly occurs in multiple gestation pregnancy tissue due to greater fetal tissue volume capable of producing alpha fetoprotein, and inaccurate pregnancy dating because maternal serum alpha fetoprotein fluctuates with gestational age. However, in patients with a singleton pregnancy and reasonably accurate pregnancy dating, such as this patient whose menstrual cycle whose menstrual period is consistent with fundal height just below the level of the umbilicus at 18 weeks of gestation, and elevated maternal serum alpha fetoprotein level suggests a congenital defect. Uh, Associated fetal abnormalities, abdominal wall defect, gastroschisis omphalocele, and open neural tube defect and myelomeningocele. These defects allow greater leakage of alpha fetoprotein into the amniotic fluid, which elevates maternal serum alpha fetoprotein level, and further evaluation is in an ultrasound to evaluate for fetal anatomy and confirm pregnancy dating. Yes, DNF or C. Sorry. Okay. Yes. Trisomy 21. Trisomy 21 due to Robertsonian translocation and produce a classic pattern of abnormal Merkel levels. In here, like trisomy 21, we need to remember the high up. Uh, Beta HCG and inhibin is up, and everything is low. Like down for Down syndrome, it is high up. It is written in the first. That's why I remember. Okay, and try for trisomy 18, inhibin is normal 18, like H for voting. In here, inhibin is normal, and rest of the going down. And neural tube defect, everything is normal, but serum maternal serum alpha fetoprotein is higher. Neural tube defect and for okay. Yes. Why we are choosing placenta previa? In anterior placenta does not is there any bleeding, painless bleeding? No associated vaginal bleeding or contraction. So, but there is increasing malodorous discharge. Placenta previa comes with bleeding for complications. Yes. Okay. Okay, it's pre-prom. So membrane rupture at less than 37 weeks of gestation prior to labor onset. So membrane rupture less than 37 weeks prior to labor onset. Risk factor is prior pre-prom, genitourinary infection and antepartum bleeding. Prior pre-prom genitourinary infection like asymptomatic bacteriuria or bacteriovaginosis and antepartum bleeding. Diagnostic is vaginal pooling or fluid from cervix, nitrogen positive fluid farming on microscopy. Management is less than 34 weeks, latency antibiotic and corticosteroid. Less than 34 weeks. Reassuring is latency antibiotic and corticosteroid less than 34 weeks, non-reassuring. Delivery more than 34 weeks, 34 or more than 34 weeks delivery. Complication preterm labor, intraamniotic infection, placental abruption, and umbilical cord prolapse. In this patient, vaginal pooling of clear fluid that demonstrate farming on microscopy is consistent with preterm pre-labor rupture of the membrane or rupture of the membrane less than 37 weeks of gestation before labor onset without contraction. Risk factor include preterm pre-labor rupture of the membrane in a previous pregnancy, antepartum bleeding, and genitourinary tract infection, particularly bacterial vaginosis. Patients with preterm pre-labor rupture of the membrane are at risk for both maternal and fetal complications, which may require immediate delivery. A common complication is placental abruption, abruptio placentae, a premature separation of the placenta from the uterus. Placental abruption can occur with preterm pre-labor rupture of the membrane in earlier gestation compared to term because of small fetal size in relation to the amniotic fluid volume and intrauterine cavity size. A large decrease in the amniotic fluid index less than 5 leads to uterine decompression which causes maternal residual vessels to shear, resulting in bleeding and separation of the placenta from the uterus. And as the abruption enlarges, patients are at risk for fetal hypoxia. Patients are at risk for fetal hypoxia and possible demise or maternal hemorrhage and possible DIC. Additional complications of preterm pre-labor rupture of the membrane include intraamniotic infection, preterm labor, umbilical cord prolapse. Due to the risk of these complications, patients with pre-prom require inpatient management. Yes, pre-prom does not affect placental attachment as placenta accreta does or location as with placenta previa because both are associated prior to rupture of the membrane. The greatest risk factor for placenta accreta via attachment to the uterine myometrium is prior to uterine surgery, cesarean delivery, vasa previa, apparent fetal blood vessels, overlying the cervix and develops during placental attachment. It is not it is not a complication of preprom. In addition, this patient's placenta is anterior, making this complication unlikely. And uterine rupture occurs secondary to increase intrauterine pressure from contraction polyhydramnios, not due to decompression as in preprom. Risk factor for uterine rupture include labor labor after uterine surgery, that is classic cesarean delivery, and acute trauma. Neither applies of this patient. Why you are choosing that? PA comes with hypotension, tachycardia, tachypnea, JVP raised sometimes. And look at the X-ray finding. Yes, superior segment of the lower lobe. It is aspiration pneumonia or aspiration pneumonitis. That's why the X-ray finding looks like this. Okay. The postpartum patient, the postpartum patient with acute onset dyspnea, hypoxemia, most likely chemical pneumonitis from aspiration of the gastric contents. Pregnancy increases the risk for aspiration due to elevated progesterone, which decreases the gastric emptying and decreases esophageal sphincter. In addition, the gravity in the uterus increases intra-abdominal pressure, promoted reflux. These obstetric factors, in combination with surgical risk factors like sedation, recumbent position, emergency intubation, likely led the patient to aspirate. Aspiration leads to chemical pneumonitis through direct pulmonary injury from gastric acid. This is ensuring inflammatory response which causes localized pulmonary edema and alveolar collapse. Atelectasis. Chemical pneumonitis manifests clinically low-grade fever, hypoxemia, and diffuse crackles on lung examination within hours of aspiration event. Chest X-ray typically shows alveolar infiltrate in the dependent segment, which in the recombinant position during the caesarean delivery and are superior segments of the lower lobe. The inflammatory process is usually self-limited and resolved with a supportive treatment, supplemental oxygen, ventilator support. Unlike aspiration pneumonia, which often has insidious presentation with cough, and chemical pneumonitis does not typically require antibiotic therapy, a minority of the patient may develop acute respiratory distress syndrome and have a more severe course. Okay, I am reading the box. Aspiration or chemical pneumonitis, gastric reflux less than esophageal, sorry, decreased esophageal sphincter, delayed gastric emptying, increase intra-abdominal pressure, delayed gastric emptying, increase intra-abdominal pressure, altered consciousness or sedation anesthesia, and endotracheal intubation nasogastric tube. Pathophysiology is aspiration of the gastric acid with direct tissue injury and lung parenchymal inflammation. Clinical presentation within hours of aspiration event within hours of aspirating event, acute onset dyspnea, low grade fever, hypoxemia, and diffuse crackle on lung examination. Chest X-ray infiltrate dependent lung segments. Okay. Sorry. In aspiration pneumonia, there may be fever, cough, high fever, cough, but in pneumonitis, as it is acute, it may not present with the high fever and cough. But the pathophysiology looks like similar, like due to aspirating something, like aspiration of the gastric juice, or maybe due to delayed gastric emptying. Okay. Close. Is there any pain? Cervical. Is it preterm labor? No. Is it placenta previa? Okay. Initially, I was right. I was thinking in the right direction. Then I go in the opposite direction. There is painless bleeding after 20 weeks. So it is placenta previa. We are distracted at looking where I can tell you, like when we see that cervical conization and this part, it got me distracted. Okay. Okay. This patient's vaginal bleeding after 20 weeks of gestation due to placenta previa, a condition a condition which covers the placenta, a condition in which in a condition in which placenta covers the cervix. These patients' risk factor for placenta previa include prior cesarean delivery, multi-parity smoking. Additional risk factor include prior placenta previa. Additional risk factor include prior placenta previa and multiple gestation. Placenta previa has a potential for massive risk of antepartum hemorrhage because cervical manipulation, even minimal manipulation from cervical manipulation, even minimal manipulation from intercourse causes partial placental detachment and painless vaginal bleeding, non-tender uterus, painless irregular contraction from the intervillous space. This bleeding is primarily of maternal origin. Therefore, many patients have reassuring fetal monitoring initially. Acceleration, no deceleration treatment depends on maternal hemodynamic stability and fetal status. Stable patients are managed expectantly as most previous resolved by the third trimester. Patients with placenta previa undergo caesarean delivery at 36 to 37 weeks of gestation prior to the onset of the labor. Yes. Lift. Yes, it is not the answer. Okay, no acceleration. That means maybe deceleration. And the most important part in the biophysical profile, look at the fetal breathing movement. It is zero. So patient is hypoxic. The baby is hypoxic. Baby is not taking any breath. So looks like uteroplacental insufficiency due to hypoxemia. Okay. Pregnancy more than 41 weeks of gestation are at increased risk of stillbirth in those, sorry, in these pregnancies. Patient placental aging leads to decreased placental function, which limits fetal perfusion during contraction and induces intermittent fetal hypoxemia. On non-stress testing fetal hypoxemia presence has led deceleration that gradually nadir after the contractions peak. As seen in this patient, progressive placental dysfunction can lead to chronic fetal hypoxemia, uteroplacental insufficiency, which causes CNS suppression and possible fetal demise. To maintain CNS function, the hypoxemic fetus preferentially distributes blood to the brain. Decreased perfusion to the kidney results in decreased urine production and oligohydramnia. Single deepest pocket less than 2 centimeter. Decreased blood supply to the peripheral muscle results in decreased fetal activity. Movement tone that may be felt by the mother. Patients with signs of suspected fetal hypoxemia, decreased fetal movement, late deceleration require biophysical profile to evaluate for fetal oxygenation. The biophysical profile includes non-stress strain and ultrasound assessment of amniotic fluid volume, fetal activity. Each biophysical profile is a biophysical profile. Each biophysical profile component of score is scored 0 or 2 for a total score 0 to 10. Normal score 8 to 10 excludes fetal hypoxemia. In contrast, abnormal biophysical profile score suggests severe hypoxemia with imminent risk of stillbirth, and delivery is typically indicated. Okay, can I call you or 2 minutes later? Okay, yes. Okay. So this patient, less than 37 weeks of gestation with vaginal pooling of nitrogen positive fluid. This patient, at less than 37 weeks of gestation with vaginal pooling of nitrogen positive fluid and a closed cervix, that is prior to labor onset, has preterm pre-labor rupture of the membrane. Risk factors are similar to those for preterm delivery, that is multiple gestation prior preterm delivery, but also indicate a history of prior preprom genital tract infection, bacterial vaginosis, antepartum bleeding. As in this patient, management is dependent on the gestational age and fetal or maternal status, because the risk for fetal maturity are balanced against maternal complication, that is intraamniotic infection, abruptio placentae. Patients with pre-prom at less than 34 weeks of gestation are at high risk for prematurity related fetal morbidity and mortality. Therefore, expected management is aimed at promoting in utero fetal development and consists of the following: prophylactic latent antibiotic. Pre-prom is commonly due to subclinical intraamniotic infection, and latency antibiotic prevent the infection from becoming fulminant and thereby increasing the time interval between the membrane rupture and delivery, prolonged latency. And antenatal corticosteroid, these are administered to promote fetal lung maturation and pneumocyte development, surfactant release, thereby reducing neonatal morbidity and mortality. Delivery is indicated if there are signs of intraamniotic infection, fetal tachycardia, uterine tenderness, or deteriorating fetal or maternal status, or if the pregnancy has reached 34 weeks of gestation. Okay, do you want me to read the box? Okay. Rupture of the membrane. Rupture of the membrane less than 34 weeks. If it is uncomplicated, expected management, latency antibiotic. If it is less than 34 weeks, expected management, latency antibiotic, ampicillin and azithromycin, corticosteroid, and fetal surveillance. If there is infection, fetal or maternal compromise, delivery, intraamniotic treatment, ampicillin and gentamicin, corticosteroid and magnesium if less than 32 weeks, and 34 to less than 37 weeks, delivery, GBS prophylaxis, penicillin G, and with or without corticosteroid. She's 33 weeks. So 34 less than 32 APT Is it like less than 32, 32 to 34, then 36? Sorry, hello? Yes, I can hear you. What was the timeline? Like less than 32? Yes. Then, okay, 32. Yes. So APT, she has got penicillin. She's 30. APT, yes. Steroid, antibiotic, and penicillin. So tocolytics. So we do not need tocolytics. So steroid. So so this patient at 33 weeks of gestation has regular painful contraction resulting in cervical dilatation. Findings consistent with preterm labor less than 37 weeks of gestation. Risk factor include prior spontaneous preterm delivery, short interpregnancy interval, short interpregnancy interval less than 6 to 18 months, and genitourinary tract infection, group streptococcus, and chlamydia trachomatis. Preterm labor management depends on the gestational age. In patients in patients at less than 34 weeks of gestation, management include attempts to delay delivery and minimize neonatal morbidity and mortality associated with preterm delivery. These interventions include antenatal corticosteroid, like intramuscular betamethasone to decrease the risk of neonatal respiratory distress syndrome. Corticosteroid promote fetal pneumocyte development and induce fetal surfactant production, fetal lung maturity. In addition, they decrease the risk of interventricular hemorrhage and necrotizing enterocolitis and overall neonatal morbidity and mortality. Penicillin to prevent vertical transmission of GBS, which occurs more frequently at preterm gestation, and nifedipine tocolytics administered 32 and 34 weeks of gestation to temporarily halt preterm contraction and delay delivery. In contrast, patients in preterm labor at 34 to 37 weeks of gestation typically receive penicillin and expected management only because the maternal risk, that is adverse effect of tocolytic medication outweighs neonatal benefit. In addition, antenatal corticosteroid may be given, but its use at this gestational age is not universal. Okay. It is not hysterectomy. It is not oxytocin. Yes. And we can do suction curettage, but 9 weeks. Patient is actively bleeding. Is it maybe suction? Maybe we do suction. I got wrong. What? I got wrong. Yes. It's spontaneous suction curettage. Okay. Spontaneous abortion less than pregnancy loss less than 20 weeks of gestation, advanced maternal age, prior spontaneous abortion, and substance use disorder. Treatment is expectant, medical induction, misoprostol, and suction curettage is infection, if infection or hemodynamic instability. So, as the patient is hemodynamically unstable, actively bleeding, that's why. Okay, and additional management, raw immunoglobulin and pathology examination, complication hemorrhage, written product of the conception, septic abortion, uterine perforation, and intrauterine adhesion. This patient at 10 weeks of gestation have this patient has 10 weeks of gestation has heavy vaginal bleeding, cramping, dilated cervix, and ultrasound revealing an intrauterine growth, intrauterine gestation in the lower uterine segment. No passage of products of conception through the cervical os, a presentation consistent with inevitable abortion, management of inevitable abortion. Management of inevitable abortion is dependent on the patient preference and hemodynamic instability. Surgical management via suction curettage is indicated for symptomatic dizziness on standing, and hemodynamically unstable hypotensive tachycardic patients with anemia for acute blood loss. Suction curettage remove the retained product of conception, allowing the uterus to fully contract around open arterial wall, which stops the bleeding. In addition, this patient requires raw immunoglobulin to prevent immunization from Rh incompatibility. And as he is Rh negative, so she needs raw immunoglobulin. Yes. Medical like misoprostol or expected management is appropriate for hemodynamically stable patient with minimal bleeding. Both management, both types of management avoid the risk of surgical complication, uterine perforation, and intrauterine adhesion, but typically require a longer time treatment is complete treatment is completed, and therefore inappropriate for bleeding symptomatic bleeding patient, those whose condition is hemodynamically unstable. Oxytocin is not effective in stimulating uterine contraction or expelling retained products of conception during the first or second trimester because few oxytocin receptors are in the uterus during early pregnancy. This patient's uterine bleeding will likely stop after the uterus and has been evacuated. A hysterectomy would be indicated for persistent bleeding after suction curettage only if all other treatments, uterine tamponade, uterine artery embolization, have failed. Okay. No, cervix malodorous. Um, cervix. Is there is no fever. Oh, citis. And yes, it cannot be. And cervix is closed, so it cannot be inevitable. Inevitable cervix is open. It is either threatened or bacterial vaginosis. Maybe we should think other option. No, no. Oh, mostly it comes with fever. That's why I know that. Okay. So this patient, so this patient, sorry, this pregnant patient with postcoital bleeding, thick postcoital bleeding and thick mucopurulent discharge most likely has acute cervicitis caused by infection with chlamydia trachomatis or Neisseria gonorrhoeae, the most prevalent sexually transmitted bacteria in women aged less than 25. Other less common symptoms of cervicitis include dysuria, dyspareunia, vulvovaginal pruritus. Pregnant patients with cervicitis often have no cervical motion tenderness, a sign of ascending upper reproductive tract infection because the gravid uterus is sealed from the lower reproductive tract to maintain uterine sterility via mucus plug. Acute cervicitis is diagnosed clinically by the presence of malodorous mucopurulent discharge and a friable cervix, bleeding easily on contact on pelvic examination, bleeding easily on contact on pelvic examination, nucleic acid amplification testing should perform for confirmation. However, empiric treatment is recommended because a delay increases the risk of obstetric complication, spontaneous abortion, preterm, pre-labor rupture of the membrane. Uh, Pregnant patients are treated empirically with ceftriaxone and azithromycin, and doxycycline is avoided due to potential teratogenic effect. There is thrombocytopenia. Is there any active bleeding or hemoglobin is low? Is it help? Hemolysis, elevated liver enzyme, low platelet, and there is hypertension too. Okay, health syndrome. This patient has 35 weeks of gestation, likely has health syndrome, hemolysis, elevated liver enzyme, low platelets. Is a life-threatening disorder related to preeclampsia. Is related to preeclampsia with severe features similar to preeclampsia. The etiology is likely abnormal placental development. Abnormal placental development during early pregnancy with the placental release of anti-angiogenic factor. These abnormalities causes widespread maternal endothelial dysfunction and dysregulation of the vascular tone. New onset hypertension. HELLP syndrome is associated with systemic microangiopathy and excessive platelet consumption, likely due to severe endothelial injury that leads to overactivation of the coagulation cascade and thrombi formation in the microvasculature. As platelets are consumed and platelet fibrin thrombi form, patient who develop thrombocytopenia and shearing of red blood cell by widespread thrombi resulting in microangiopathic hemolytic anemia, as evidenced by patients' indirect hyperbilirubinemia, which is a detrimental to liver. The hepatocellular injury from vasospasm and hepatic portal system thrombi leads to distension of the hepatic glycan capsule, causing worsening right upper quadrant pain with nausea, vomiting, and elevated transaminase. Other potential complications include liver rupture, eclampsia, intrauterine fetal demise. Patients with HELLP syndrome require prompt delivery because removal of the placenta is the definitive cure. Okay, reading the box. A HELLP syndrome, nausea, vomiting, right upper quadrant pain, headache, visual changes, hypertension. Lab findings is microangiopathic hemolytic anemia, elevated liver enzyme, thrombocytopenia, and proteinuria. Treatment delivery: magnesium sulfate for seizure prophylaxis and antihypertensive hydralazine. Complication is apraxia placentae, subcapsular liver hematoma, acute renal failure, and pulmonary edema and GIC. And GIC. Okay. Is it serum bilirubin? Oh, no, 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 no. Okay, I got wrong. Okay. The most common cause of jitteriness in patients of infants of diabetic mother is hypoglycemia. However, this patient's serum glucose is normal more than 40 milligram per deciliter, making sorry is now normal more than 40. 70 for babies. I think that cut mark is low, making hypocalcemia the likely cause. The pathophysiology of the hypocalcemia in IDM infants of diabetic mother relates to maternal hypomagnesemia is caused by osmotic diuresis in the setting of poorly controlled GDM. Low fetal magnesium concentration reflect maternal level lead to PTH suppression and low calcium level in infant. Most newborn most newborn with hypocalcemia are asymptomatic. Normalizing of the calcium level without intervention within days of birth. So routine screening is not required. However, symptomatic hypocalcemia can present with jitteriness, respiratory symptoms, apnea, stridor from laryngospasm, and wheezing from bronchospasm. If severe seizures, severe seizures, additional findings in infants of diabetic mother may reflect consequence of excessive maternally transferred glucose such as increased fetal fat and glycogen storage disease leading to macrosomia in the infant as seen in here. If hypoglycemia in symptomatic infants of diabetic mother is resolved, a serum calcium should be obtained to confirm the diagnosis of hypocalcemia. Management typically involves correction of magnesium then calcium. Okay. No, she's full dilated. Why we should do C-section? Hmm, you are right. Oof, sorry. Oof, it's rupture. She's fully okay. She's prior uterine rupture. So this laboring patient with sudden onset abdominal pain likely has uterine rupture. Sudden onset abdominal pain likely has uterine rupture. A full thickness myometrial tear. Uterine rupture that typically occurs in patient with prior uterine surgery, prior caesarean delivery, regardless of subcutaneous vaginal delivery, because inelastic scar tissue and can separate with contraction. When the uterus ruptures, when the uterine ruptures, maternal and fetal compromise occurs by multiple mechanisms. If placenta is involved, fetal perfusion is disrupted, leading to fetal hypoxia, late deceleration, prolonged bradycardia. If the umbilical cord prolapses into the maternal abdomen, cord compression may increase, variable deceleration because either or both are likely to occur. An abrupt fetal heart rate tracing abnormality is the most common finding of uterine rupture. Disordered contraction occur because ruptured myometrial fibers cannot contract in unison. This is often evidenced by progressively decreasing contraction amplitude, staircase sign on tochodinometry staircase sign. Partial fetal delivery in the maternal abdomen can cause fetal head retraction, +1 to -2 station, and loss of fetal station. Myometrial tearing can Myometrial tearing causes severe abdominal pain and massive intra-abdominal bleeding, which may result in hemodynamic instability. Uterine rupture is an obstetric emergency, requires emergency laparotomy and caesarean delivery or immediate delivery and uterine rupture. Yes, the Mac Roberts the Mac Roberts maneuver with suprapubic pressure facilitates the delivery in patients with shoulder dystocia. This condition can present with fetal head retraction against the perineum turtle sign. However, it does not cause sudden severe abdominal pain. Vacuum-assisted vaginal delivery may be performed in patients who are 10 centimeter dilated, requires immediate delivery, non-reassuring fetal heart rate. In this patient, however, fetal head retraction to -2 station has been made with procedure unsafe. In addition, vaginal delivery does not address with patient's uterine rupture, which requires laparotomy to repair. And oxytocin infusion increases the contraction frequency, strength in patients with inadequate contraction. However, it is not administered in the setting of acute fetal bradycardia due to the risk of further fetal compromise. It is deceleration, late deceleration, not contracting with 6 centimeter dilated. And she hemodynamically unstable. I think that we should do CS. Maybe right. Okay. Okay. Intrapartum electronic fetal heart rate monitoring is intrapartum electronic fetal heart rate monitoring is used to assess fetal brain oxygenation status a well oxygenated brain a well oxygenated brain provides autonomic control of the heart. Fetal heart rate patterns are divided into three categories based on risk of fetal hypoxia. Category 1 fetal heart rate has a baseline heart rate 110 by 160 per minute with moderate variability. Average amplitude 6 to 25 with no deceleration. This patient has low risk for fetal hypoxia. Variation from this pattern are suggestive of fetal hypoxia which can lead to acidemia and possible demise. This patient fetal heart rate tracing has absent variability plus recurrent late deceleration. uh, this patient fetal heart rate tracing has absent variability and plus recurrent late deceleration. Late deceleration with more than 50% of the contraction diagnostic of category 3 fetal heart rate tracing. Patients with category 3 tracing have an increased risk of severe fetal hypoxia and a subsequent hypoxic brain injury or demise as seen in this patient with late deceleration, which are likely due to uteroplacental insufficiency. The initial management of category 3 tracing is with maternal repositioning or and other intrauterine resuscitative intervention, oxygen administration, IV fluid, discontinuing uterotonics that improve uteroplacental blood flow and fetal oxygenation. Patients remote patients remote from delivery not completely 10 centimeter dilated who do not improve with initial resuscitative measure required and immediate cesarean delivery. And option A, amnioinfusion is used in category 3 tracing with recurrent variable deceleration because amnioinfusion may help to relieve the umbilical cord compression that causes this deceleration. It is not indicated in patients with recurrent late deceleration. Yes. A biophysical profile is not used during the intrapartum because it does not change the management and may delay for appropriate intervention. Yes, yes, yes.